Funding for Yale Cancer Answers is provided by Smilo Cancer Hospital. Welcome to Yale Cancer Answers with Dr. Anees Chagpar. Yale Cancer Answers features the latest information on cancer care by welcoming oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation about skin cancer with Dr. James Clune. Dr. Clune is an associate professor of plastic surgery at the Yale School of Medicine, where Dr. Chagpar is a professor of surgical oncology.
So, Jim, maybe we can start off by you telling us a little bit more about yourself and what it is you do.
Sure. It's sort of a combination of two fields. I treat patients with skin cancer and soft tissue tumors, and I'm also a plastic surgeon, so I also help with the reconstructive efforts after their resection of their skin cancers or soft tissue tumors.
So let's talk about skin cancer, given that it is Skin Cancer Awareness Month. Can you kind of lay out a landscape for us of what kinds of skin cancers there are in the world? I mean, some of us know about really bad skin cancers like melanoma, but there are also not so bad skin cancers like basal cell cancer. So can you kind of give us a landscape of what skin cancer really looks like?
Sure. So as you mentioned, the most common types of skin cancers are squamous cell carcinoma and basal cell carcinoma, which are superficial skin cancers for the most part that originate from their own unique cells, but they're much more common and they can be locally destructive and a problem in the local area, but rarely metastasize. Whereas some of the more deadly skin cancers are melanoma, Merkel cell carcinoma, much less common, but they can metastasize at a much higher rate and can shorten the lifespan much more often than squamous cell or basal cell.
So in terms of risk factors, I think most people these days know that ultraviolet radiation, right, being exposed to the sun is a key risk factor for developing skin cancer. Are there other risk factors? And in particular, are there risk factors that predispose people to one kind of skin cancer versus another?
Sure. So family history is a big predictor of whether or not you might be afflicted with skin cancer. So if you have grandparents or parents, direct relatives that have had skin cancer in the past, then you have to be particularly careful in the history of sunburns, some of the obvious things like that. There are genetic mutations that run in families that can predilect you to having a skin cancer, and those are things that we would test for if we suspected that when we meet you. And the other thing is that there are skin cancers that are more common in patients who have had, say, immunosuppression due to lupus or transplant medications. And we do see quite a number of patients who have had transplant surgeries, and then down the line, due to the immunosuppression from the regimen they're on, they do have an increased rate of skin cancer.
And so those risk factors, do they increase your risk of all kinds of skin cancers equally? In other words, they would increase your risk of melanoma just as much as they would increase your risk of, say, a squamous cell or a basal cell cancer? Or do those give you more of a predilection for one or the other type?
So if you're talking about a family history, it can just be a predilection of any skin cancer because it shows you have a sensitivity to UV radiation. And then if you're talking about a mutation, then it's going to be a specific skin cancer, such as basal cell, because you have something that runs in the family that particularly causes basal cell carcinoma. Okay.
And so then the next question is, who gets these? I mean, aside from the people who have a family history or have a genetic mutation, are skin cancers really more common in males versus females? I would imagine they're certainly more common in Caucasians versus African Americans. Tell us more about the kind of the groupings of people who get skin cancers.
Right. So skin cancer is more common in the lighter complexion that you have, the more likely it is that you could get a skin cancer. But that's not to say that skin cancer is impossible if you have darker complexion. In fact, we see a significant amount of acral type melanoma, which is melanoma that you see on the palms of the feet or on the tops of the feet or on the soles of the feet and the hands in patients with darker complexions. And one thing about this patient population is it's maybe people aren't aware of it, so you don't suspect that they would have a skin cancer because we always talk about skin cancer being something that affects Caucasian people. But if you have darker skin complexion and you have a lump or a bump on the sole, that can be ignored for many years, thinking it could be a cyst or something, a scar tissue, when in fact it could be a melanoma or some other type of skin cancer. And sometimes these patients present very late because of that. So it can be very deadly for this patient population if it's ignored.
Yeah. When we think about the soles of the feet, we often think that people wear shoes. Are those skin cancers that occur on the soles of the feet, are those equally predisposed by exposure to sunlight, or are those the kinds of cancers that just can occur because, well, it's bum bad luck and they've got to occur in somebody?
Right. Yeah. I mean, it's unlikely that you've gotten a lot of sunburns on the soles of your feet. That's right. So most likely these are due to a different pathway. And when we look at the genetics and mutations that are in these skin cancers, they're very different from a skin cancer in a sun-exposed area, say on the scalp in a Caucasian. In fact, the number of mutations in a scalp squamous cell or melanoma from UV radiation, the number of mutations are massive because it's from bombardment of UV light, whereas on the soles of the feet and the palms of the hand, the mutational burden, as we call it, is very, very low. In fact, it's just a very few specific mutations that cause the skin cancer to arise. So as of now, we're not really sure exactly why these happen. There's some theories that perhaps trauma, repetitive trauma to a toe can cause a skin cancer to occur in the acral area, but it's not proven, and it's more historical.
Yeah. When you talk about cancers that occur on the scalp, I mean, certainly we think about the scalp being, the closest to the sun most often, but, a lot of people don't think about skin cancers occurring on the scalp because, well, most people have, and not all people, but most people have a head of hair, and we think, our hair is going to protect us from the sun, or at least it keeps any kind of skin cancers out of sight and out of mind. Can you talk a little bit more about how common skin cancers are on the scalp and what you should be looking for?
Yeah, so skin cancers are quite common on the scalp, particularly amongst men. It's whereas men tend to get their skin cancers on the face and scalp and forearms, and females are more likely often to get it in the legs and those areas. But the scalp I've seen skin cancer on the scalp of men and women. And again, similar to patients with acral melanoma on the feet, it's an area that may be missed if you have a full head of hair, and often the referrals that we get for skin cancer on the scalp are found by barbers and hairdressers, and they notice a mole or a pigmented area that's been there for many years and seems to be changing, and they'll let their client know that they need to get it checked out. So it is a missed area, but it is common, especially amongst men.
And so, when you talk about all of these areas where you can get skin cancers that are common but that are often missed, it makes us think about, getting those areas checked. So is there a recommendation that everybody should go and see a dermatologist once a year and get a head-to-toe skin exam, or is that only for people who are really at risk? Or what is your advice in terms of, checking for these areas that might be skin cancers?
Right. Yeah, that's a difficult question, actually. It seems simple, but it's harder because if everybody in the world was recommended to see a dermatologist, there wouldn't be enough dermatologists. But if you have risk factors such as fair skin, a history of sunburns, family history, you're a transplant patient, if you have risk factors that are known, then you should be seeing a dermatologist at least once a year. If you've been diagnosed with a skin cancer such as melanoma, we tell our melanoma patients to see a dermatologist every 3 to 6 months forever. So it really depends on your risk factors, how often you need to see a dermatologist. But one general rule of thumb is to take a look at yourself every 6 months in the mirror, or even with photographs if you wanted to, or take a pic, and then keep an eye on your moles and any skin lesions that you've looked at, that you've noticed or your partner have noticed. And then if they change, that's when you need to see a dermatologist. But really, if you have risk factors, you should be seeing a dermatologist every year.
Yeah. So I think it's great to have the adage of, if you see something, say something. And certainly if you know that something is changing, to go and see a dermatologist and get it checked out. but sometimes that's just early detection. And we know that many skin cancers can be prevented. So can you talk a little bit about prevention strategies and are they really effective? So when people say, slap on some sunscreen and slip on a shirt and slap on a hat, are those really effective strategies or is it just overkill?
Right. So we know that skin cancers, the vast majority of them are caused by UV radiation. So it would make sense that if we limit the UV radiation that we have, then we're less likely to get a skin cancer. In addition, we know that patients who have presented with more than a few sunburns are more likely to have a skin cancer. So we know this is what it's caused by. So it makes sense that if we can reduce the amount of UV radiation that we're getting and it's cumulative over time, then we can reduce the chances of having a skin cancer. How to prevent it is difficult because everyone spends time outside at some point in their life, and you can't always be 100% covered. And then we also see that most of this sun damage is done in the teenage years and as children, and less likely in your 20s, 30s, and 40s when you have a job and you're indoors most of the time. But I think prevention really starts early in life, and I think that's something that we should be focusing on more as well as teen years, early 20s, the time that you spend a lot of time outside. And I think this is sort of a message for parents is that you need to keep your kids from getting a sunburn in those early years because that we see the damage way down the line.
So is it at all reversible? Like, let's suppose you're listening to this show now and you're past your teens and your 20s and you're thinking to yourself, gosh, like when I was a teenager, I never wore sunscreen. I was out in the sun all the time. Yeah, I got some sunburns. Is there any way to kind of reverse the damage that's already been done, or is that horse kind of out of the barn?
Well, unfortunately, you can't reverse the UV radiation damage, but what you can do is try and catch these lesions early. And there are treatments, topical chemo creams, so to speak, such as Effudex or 5-fluorouracil, which you would put on and then be prescribed by a dermatologist to put on an area that has a history of sun exposure and perhaps precancerous lesions, what we call actinic keratosis. And these treatments can be effective in slowing the progress of what would be possibly a squamous cell carcinoma in the future. So you can't reverse the damage, but you might be able to catch these things and treat them before they become a skin cancer.
And certainly you can, adopt good practices now because it's better late than never, right?
Right.
So the other question that I have is, let's suppose that you are somebody at risk. These days we see a lot of advertisements for, UV protective clothing that's kind of got UV protection built in. It's usually far more expensive than regular clothes. But some people might think, well, geez, if it actually prevents me from getting a skin cancer, then it's worth it. Do those kinds of clothes really have any data behind them?
In terms of data, it again goes back to UV light exposure. So we know that if you have a history of skin cancer, it correlates well with the history of being exposed to UV light. So these clothing, if they're properly made and tested, they do block the light. The best way to test the clothing is to put your head inside of it, and you should not be able to see any light through that clothing. And so if you're testing one of those sunblock shirts, which I have a few of because the sunscreen, again, if you sweat, it wipes off, and I think the sun-blocking clothing is actually quite effective, but you need to check it because it will break down over time. But I think it is quite effective, and it is expensive, those clothes. Some of those shirts are $60, $70, but then again, a tube of sunblock is also very expensive these days. And, if you're properly applying the sunblock, you're going to use a lot of sunblock in a family of 5 or so.
Good point. Well, we need to take a short break for a medical minute, but please stay tuned to learn more about the care of patients with skin cancer in honor of Skin Cancer Awareness Month with my guest, Dr. James Clune.
Support for Yale Cancer Answers comes from Smilow Cancer Hospital, where their prostate and urologic cancers program provides a multi-specialty team dedicated to managing the diagnosis, evaluation, and treatment of bladder cancer. SmiloCancerHospital.org. There are over 16.9 million cancer survivors in the U.S. and over 240,000 here in Connecticut. Completing treatment for cancer is a very exciting milestone, but cancer and its treatment can be a life-changing experience. The return to normal activities and relationships may be difficult, and cancer survivors may face other long-term side effects of cancer, including heart problems, osteoporosis, fertility issues, and an increased risk of second cancers. Resources for cancer survivors are available at federally designated comprehensive cancer centers, such as the Yale Cancer Center and its Milo Cancer Hospital, to keep cancer survivors well and focused on healthy living. The Milo Cancer Hospital Survivorship Clinic focuses on providing guidance and direction to empower survivors to take steps to maximize their health, quality of life, and longevity. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Welcome back to Yale Cancer Answers. This is Dr. Anish Chagpar, and I'm joined tonight by my guest, Dr. James Clune. We're talking about the care of patients with skin cancer. Now, right before the break, we were talking about kind of how we can prevent skin cancer with sunblock, often using sun protective clothing. And one thing that you mentioned, Jim, when we were talking about kind of the fact that we couldn't turn back the time, right? A lot of times we've had sunburns as children or teenagers or in our early 20s, and that damage to the DNA is done. So we talked a little bit about checking yourself or going to a dermatologist if you have risk factors and seeing if any of your moles or things change. Let's suppose you are doing a skin exam and something has changed. You go to the dermatologist. What happens then? How is the diagnosis made? And how frequently is what they find a precancer versus a true cancer?
Right. So you go to the dermatologist's office and you show them what you're concerned about. And I think one of the points that is made to me in my office every day by my patients is that they have persisted a little bit to ask the dermatologist for a biopsy, because you've been seeing that every day. You've seen how it changed. The dermatologist may not have seen how it changed. So I think it's totally appropriate to say, can you biopsy this for me? Because it's your body and you should help direct your care. And you've been watching this lesion. So, and then when the agreement is made to biopsy, there's many different ways that something can be biopsied. But for the most part, it's going to be, you're going to get a little numbing medicine, and then they're going to scrape a piece of that off with a little blade, or they'll punch a little hole in it with a little, almost like the little old-fashioned hole punchers that we would use for our 3-ring binders. And then they would send that to the lab, and it'll be tested to see what it is. For the most part, the dermatologists are amazing in terms of their eye and what they can see as a precancerous lesion versus a cancerous lesion. So some of these precancerous lesions, what we call actinic keratosis, they may just freeze off, because that would be curative. It's called a destruction of the lesion with basically a freezing spray, and that actually treats that lesion, that precancerous lesion.
And so how often do we see actinic keratoses, and what do those look like versus a true full-blown skin cancer? Right.
So an actinic keratosis looks like almost like a little dried scab. It's usually slightly clear in color, and then depending on the pigment of your skin, and the base of it will be more like the pigment of your skin. And they often, you can often scratch them off yourself and almost feel like, oh, what was that thing? That may have been an actinic keratosis. And the older we get, the more we get of them due to, just time. And the dermatologists can really recognize these from across the room. Whereas a skin cancer, often you may scrape something off, it grows right back. They don't, if it's an open wound associated with a skin cancer, it doesn't heal. These are all signs that this is probably a malignancy rather than a precancerous lesion that just flakes off.
Yeah. And so let's suppose a biopsy is done. Now, at the top of the show, you were mentioning that there's a whole variety of different kinds of skin cancers. There are squamous cells and basal cell cancers, which are really common, but tend to be really more localized, less likely to metastasize to other parts of your body. And then there are things like melanoma, which are more deadly and more likely to metastasize. So if you have a biopsy, and depending on the type of the cancer, presumably those will be treated a little bit differently, right?
Right. So if you have a squamous cell or a basal cell, they'll biopsy it, and then the pathologist will tell them how big it was, basically, and how serious that particular squamous cell or basal cell was. For the most part, Sometimes the biopsy is the treatment itself. They scrape it off and their margins, meaning that they got all of the cancer with the biopsy, so you're done right then and there and you don't need to do anything more. Sometimes they'll say the margin is still involved and they recommend that you have it fully excised, meaning that it needs to be cut out by somebody. And that could be the dermatologist. Another type of dermatologist is called a Mohs surgeon, where they take the skin cancer out and they check the margins as they go to make sure that they don't have to take too much skin. Or you may be referred to a surgeon such as myself, where we take it out and send it to the pathologist to check the margins. There are a number of ways to get it out. And then some people will have multiple superficial skin cancers called squamous cell carcinoma in situ. And sometimes those will just be frozen off by the dermatologist or treated with a topical cream as well if they're all superficial and there's a bunch of them in one place.
What about cancers that are more than just a basal cell or a squamous cell? What if it's a melanoma? How are those treated?
Right. So for the most part, there's a couple types of melanoma, one being a melanoma in situ, meaning it hasn't gone below the upper layer of the skin. And those are sometimes cut out by the local dermatologist because you don't need any sort of medical oncology follow-up after that because it was superficial and doesn't have the potential in most cases to spread. But anything that goes below the epidermis, which is the upper layer of skin, into the dermis, we call an invasive melanoma. And that should be referred to somebody who specializes in melanoma cancer care as a surgeon, such as myself or my partner, Dr. Alino or Dr. Khan. And we all specialize in removing melanomas. And depending on the depth and some of the characteristics of the melanoma, we'll remove the melanoma, and we will also often take a lymph node out of the nearest nodal basin, we call it, to see if that cancer has spread at all. And I can go into more detail about that if you needed.
Yeah, because, I mean, you never mentioned the lymph nodes with the squamous cell or basal cell. So are lymph nodes important in those? And why are lymph nodes important in melanoma?
The chances of having a run-of-the-mill squamous cell carcinoma and a normal skin cancer, so to speak, the chances of having lymph node involvement are less than 1%. And then the chances of having nodal involvement in a basal cell carcinoma is less than 0.1%. Whereas in melanoma, if you have an invasive melanoma, and then we determine how serious a melanoma is based on how deep it is, once you get to the 0.8 millimeter melanoma depth or 1 millimeter melanoma depth, the incidence of lymph node involvement is up to 20%. And then the deeper the melanoma, up to about 4 millimeters, the chances of having involved lymph nodes increases all the way up to 40%. So if you have a melanoma and it's 2 millimeters in depth, your chances of having lymph node involvement are somewhere around 20-25%. So at that point, we would definitely talk to you about taking a lymph node out. And that same is true for a type of skin cancer called Merkel cell carcinoma, which all Merkel cell carcinomas have at least a 20% chance of nodal involvement. So the squamous cells and basal cells, unless you're a transplant patient, which in that population we do often do sentinel node biopsies where we take a lymph node out. For the most part, we don't do lymph node biopsies. But with these other cancers like melanoma and Merkel cell, there is a much higher rate of nodal involvement, and that can really help us indicate whether or not you're going to need medications, how closely you should be followed. Should we be looking in other parts of your body for the spread of these skin cancers?
I mean, when you think about skin cancers being only a millimeter deep and still being able to get to lymph nodes and other parts of your body, that tells you just how aggressive these little cancers can be. So, Jim, what happens after that? Let's suppose you do a biopsy. It's an invasive cancer. They get sent to you, and you're planning on taking this thing out and checking the lymph nodes. Do you do that first, or do you do those staging studies to see whether it's in other parts of the body first? How does that all work? And if it is in other parts of the body, how does that change things, if at all?
Right. So we typically start with surgery first, as long as we don't feel any lymph nodes in the armpits or the groin, depending on where the melanoma is. So let's use an example of a melanoma on the hand. So if you have a melanoma on the hand, the most likely place that that's going to show up besides on your hand is in your armpit where your lymph nodes are. If we don't feel any lymph nodes in there and we feel that the disease that you may have is all microscopic, meaning we can't detect it by looking at or feeling, then we would proceed to the operating room. We would go to the operating room, we'd take the melanoma out of the hand, and we'd also make an incision in the armpit and take some of the lymph nodes out, to send to the lab. And then we would send the lymph nodes out, close the hand, and then we'd send the patient home to recover. About a week later, we get the results of all those tests. If the melanoma is gone from the hand, meaning our margins are negative, then we're done with the hand portion of it. And if the melanoma is in the lymph nodes in the armpit, then we have to basically put our heads together and say, okay, what's next? We used to do more surgery. We'd take the lymph nodes out of the armpit, all the remaining ones, thinking that perhaps that would stop the spread of the disease and increase survival. But there's been a few studies done, one called MSLT1 and MSLT2, which are our trials that we did to find out if taking all the lymph nodes out was going to increase survival. We found out that it didn't. But we still do the lymph node biopsies to help predict whether or not the patient's going to recur later on and how closely we need to watch them. So if it's in your lymph nodes, then we have to make a decision. Should we give you some sort of medication, perhaps, to kill whatever microscopic melanoma cells may be floating around in your body? But to help us make that decision, then we start getting deeper into imaging and CAT scans and PET scans, which are different imaging modalities we have to look at your liver and your lungs. We get a brain MRI to look at your brain to see if there's any other disease throughout the body. The reason we do that after the lymph node biopsy is because the lymph node biopsy is the most accurate way to detect microscopic disease. We're talking just a few cells in a group of a billion. Whereas the PET scan and CAT scan, you really need a lot of cells in one spot to be imaged on the PET scan and CAT scan. So we do the microscopic work first, and then if that's positive, then we move on to look for the macroscopic disease. And if you really do see something somewhere else in your body, like your liver, your lung, and we get a biopsy of those, and those are positive for melanoma, then we're definitely going to be talking to you about having what's called immunotherapy, which is the type of medications that we use to treat melanoma.
If a patient has disease in their lymph node, and even before, like even if they don't have distant metastatic disease in their brain or their liver, immunotherapy is still an option for them. Is that right?
That's right. The indications for immunotherapy or the guidelines that allow you to offer this as a treatment have expanded to even patients without melanoma in their lymph nodes, but a very aggressive melanoma on the piece of skin on their body. Even some of those patients are being offered immunotherapy now. The question that still remains is, does this increase the patient's survival overall, or are we just increasing the amount of time that the disease stays away from them? So that's something that's still being tested, but you're right. The immunotherapy can be offered to a patient, even if it's not in their lymph nodes, but they have an aggressive melanoma. And then as soon as you have a melanoma in your lymph nodes, that also opens up the eligibility for immunotherapy. And then that's a case-by-case basis discussion that we have with the medical oncologist, seeing what the patient thinks, because there are, of course, side effects to the immunotherapy that need to be discussed as well.
Yeah, but it raises the question, right? If the treatment, i.e. immunotherapy, is going to be given regardless of what you find on the scans, then the scans are really there to kind of give you a sense of prognosis more than anything else. Is that right?
Sometimes, but it helps guide you a little bit in terms of what medications you're going to give, because we have multiple options available now. So if you have melanoma in your liver, which could be deadly, you're probably going to get 2 drugs from the immunotherapy. Whereas if you only have 4 cells in a lymph node in your armpit and the rest of your body has no disease, you might just be getting 1 drug for immunotherapy, and the toxicity of having 1 drug versus 2 is much less.
Dr. James Clune is an associate professor of plastic surgery at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.